Male sexual dysfunction is a series of conditions, mostly notably including the erectile dysfunction, pyrogenic disease, and premature ejaculation. And Madam has rightly talked about the retrograde ejaculation, but its components will be very less. And Simar Madam has rightly pointed out, it is not a dysfunction, it is a disease. It is a sphincter disease, it is not a dysfunction. So ejaculatory dysfunction of retrograde ejaculation, it don't come in a male sexual dysfunction. Am I right, madam? So,
Yes.
despite major progress in our understanding of sexual dysfunction and function and dysfunction, human sexuality issues are usually not included in medical school curriculum. There are so many doctors, those who are doing reproductive medicine fellowship, their teacher might not have taken this in their curriculum. So sexual health problems are largely neglected in most of the medical and clinical practice. Highest effect of sexual problems are in brief on the individual, on the partner, on the relationship. So on the individual, feelings are inadequate, reduced esteem, frustration, anxiety, depression, avoidance, fault finding. Every time, whenever there is a something is there, fault is always either in the part of male or female. There may be anxiety, frustration, sometimes anger, deflected self-esteem, depression, and avoidance. You see, avoidance and negligence are the most common things found if we take the history. They say that they are not taking care of me, she is not taking care of me, and he is not taking care of her. Unhappiness, non-sexual relationship, impaired communication between sexual and non-sexual, violence due to jealousy, marital breakdown, sometimes divorce. These all are causing male and female both sexual dysfunction. Most common dysfunction is erectile dysfunction, just like vaginismus or GPPD in female, genitopelvic pain penetration disorder. So, what is the definition? What is the prevalence? Etiology, investigation, medical and surgical management, and novel therapies. We will discuss one by one. So, how we define erectile dysfunction? So, erectile dysfunction is DSM-5 classifies erectile disorder and belongs to a group of sexual dysfunction disorder typically characterized by clinically significant inability to respond to sexually or experience sexual pleasure. Sometimes it not be that the female sexual partner should be there, because of some visual or there is a nocturnal erection is always there in a male. During daily night there is a nocturnal erection. It lasts for 5 to 10 seconds or sometimes for 30 seconds. So it is there. So in almost all 75 to 100% female male sexual activity, the experience of at least one of the three following symptoms will be there. Marked difficulty in obtaining an erection during sexual activity. There is marked difficulty in maintaining an erection until the completion of sexual activity, or marked decrease in erectile rigidity. If any of this, all these following three symptoms, or one of this is there, then it is caused as erectile dysfunction. The symptoms are above persistent or approximately lasted for at least 6 months. The symptoms above causes significant distress in the individual. The dysfunction cannot be better explained by non-sexual mental disorder or medical condition, the effect of drug or medication, or severe relationship distress or other significant stresses. What is the prevalence in India? Subject with known diagnosable male sexual disorder. Frequency is 585, percentage is 78%. Subjects with diagnosed male sexual disorder, 21% is already diagnosed that they have got sexual dysfunction. They have got sexual dysfunction but they don't know. So if we see erectile dysfunction counting the highest, that is 15.77%. Male hypoactive sexual desire is 2.8 and premature ejaculation comes to 8.76. What is the severity of erectile dysfunction? Severe erectile dysfunction. There is no erection at all. Erection is there but is not up to the mark. Mild to moderate erectile dysfunction, and mild erectile dysfunction is 19%. So most common is there is erection but after some time it gets looser. So what is the prevalence? It is increasing with the age. Erectile dysfunction is 7% around the 18 to 29 year of age. But the age advances, you can see in 70 to 80 year men, 53% are there, those who have got erectile dysfunction. But here we are not worried for this 70 to 80 year couple. Here we are worried for 50 to 59, 20% are there, and at that they are getting the senior citizen, 34% of male are suffering from erectile dysfunction. So how we classify erectile dysfunction? Primary, they had never attained any erection, that is lifelong, or sometimes secondary, that may be because of generalized or situational. So many times situations are that everybody agrees that those who are practicing IVF, they are not able to give semen at a time of ICSI or at a time of IVF. That is a situational erectile dysfunction. There may be because of organic cause, psychological cause, or sometimes mixed because of organic and psychological. So how psychological and organelle dysfunction? What are the parameters we have to see? What is the onset of disorder? If there is psychogenic, then situational with defined onset associated with specific emotional event, organic, insidious. Participating event may be psychogenic, or if there is organic, there may be a debilitating disease, CNS abnormality, there may be history of penile trauma, or patient is taking drugs which is interfering with the erection. Erectile dysfunction before intromission may be present for psychological, but usually absent except in patient with pelvic steel phenomena. Erectile function after intromission, variable with different parameters, but usually absent in organic cause because there is no erection in organic cause. Erectile dysfunction response after sexual stimuli, it is usually present in psychogenic and usually absent in organic. Same times psychogenic and dysfunction, we can see that these all are nocturnal panel. We can see that erectile function to stimuli in organic, it is usually absent. Nocturne or morning erection, initially present in full, most in long lasting, but because of psychogenic case, it not be there. Causes of this disorder may be episodic or there is transient loose erection. Associated ejaculatory disorder like premature ejaculation, intermittent loss ejaculation. You see, this is a very good slide. Nocturnal penile tumescence. Total time 90 to 180 minutes during night. There is change in circumference of more than 70%. Penile brachial index more than 35 seconds. It is there, but if there is organic cause, there may be less than 40 seconds or there is less than 2 centimeter change in the circumference. How it is related to cardiovascular disease? Erectile dysfunction is maybe endothelial dysfunction. Penis is a barometer of endothelial health. Believe me, so many times patient is suffering from erectile dysfunction and we gone for his cholesterol level, we gone for his heart factor, we can see that lot of atherosclerosis is there. Patient has got severe coronary artery disease and because of that there is erectile dysfunction. This is because of the secondary erectile dysfunction. Erectile dysfunction may reflect endothelial function as a signal early injury that are lesser benefits as clinically apparent of the vascular disease. ED and prevental cardiovascular medications are linked and can be caused to get men's attention that now take care of your heart if you want to have a good erectile dysfunction. So erectile dysfunction is barometer of patient's health. Don't just see this erectile dysfunction as a dysfunction of the sexual disease. You can also see that patients are suffering from diabetes, hypertension, obesity and dyslipidemia. This is barometer that if you are doing very good sex before all this disease and now you are not getting the erection, see that. Control your diabetes, control your hypertension, correct your obesity, decrease BMI, take the dyslipidemic drug, take the torvastatin, so reduce the cholesterol, so decrease the atherosclerosis. It may increase your sexual desire and it may decrease your erectile dysfunction. So erectile dysfunction is closely linked with the cardiovascular disease. Diabetes has got 40%, hypertension has got 50%, hyperlipidemia 35%. You see combined heart disease, all these patients has got 60% comorbidities associated with erectile dysfunction, that is the cardiovascular disease. Share the understanding of endothelial dysfunction. Erectile dysfunction and hypertension goes hand to hand. 33% of over incidence of erectile dysfunction in hypertension cases, antihypertensive like beta blockers. Those patients who just say that before my hypertension treatment, I am able to do sex very well, but after taking metoprolol, bisoprolol, atenolol, my sexual desire is decreasing. Just ask a leading question: which antihypertensive you take? And just after stopping that beta blocker or change of that antihypertensive for beta blocker to another antihypertensive drug, her erectile dysfunction is gone. The best antihypertensive therapies are ARBs. If diuretics are needed, give indapamide. That is furosemide like indapamide. If beta blocker needed, if suppose there is nothing like, then use nebivolol. Don't use atenolol, metoprolol or bisoprolol. Always use nebivolol. But if you got ARBs are most effective in the early hypertension, and erectile dysfunction will be gone. If patient has got diabetes, percentage of comorbidities and complications are very high. 30% of all diabetic men has got erectile dysfunction. 50% of diabetic men of 60 years of age has got erectile dysfunction. And those who got diabetes more than 10-year old, they are suffering from 60% suffering from erectile dysfunction. Lower urinary tract symptoms, lower urinary tract infections is independent risk factor, and prevalence of lower urinary tract infection was 74% in men from 60 to 40 to 69 year age with erectile dysfunction. So erectile dysfunction is significantly risk factor for depression also. That why I am not able to give my 100% to my wife. So how you evaluate a case of erectile dysfunction in your clinic? Are there any diagnostic tests available? Yes. This is a very good monogram. Whenever you want to evaluate a patient with erectile dysfunction, they usually self-reported. First, ask the medical and psychosexual history. Use of validated instruments like ILA. Identify the sexual problem other than erectile dysfunction. Identify common causes. Identify reversible risk factor and assess the psychological. Then goes for focused examination. Examine the penis, vas, testes, scrotum. Do the test on the lateral side. Just do the flickering, and you can see that because of S1 stimulation, testis is going inside. Patient should feel that you have done something. That other erectile dysfunction, if you don't look at the patient, and it is my humble request, whenever you are a female gynecologist and male patient comes to you, always examine in front of any male. Just like we are examining all female in front of female, our attendants. As a female, if you want to examine the male, always take help of your husband or some assistant and examine the male and see that with sometimes with good semen counts, you see that testis is only peanuts. So don't believe that report. Just whenever they are coming for erectile dysfunction, examine the penis, scrotum, vas, give them the valsalva, see for any pempiniform plexus dilatation is there or not. If patient is suffering from varicocele, you have to see the penile deformities. You have to see for prosthetic disease. As a male, we are able to, or you can also do per rectal examination, particularly in cases of 60, and you can see BPH, benign prostatic hyperplasia, and because of that there is erectile dysfunction, or there is hypogonial signs, and we also see CVS and CNS status. Then we have to see for glucose lipid profile test. We can go for testosterone examination, particularly in the morning, and we have to see for pre-testosterone. Specialized diagnostic tests are nocturnal penile tumescence and rigidity test. This is very common test, and it is very easy. You have to do for at least 2 nights. Functional erectile mechanism is indicated by an erectile event of at least 60% rigidity recorded on the tip of penis that lasts for more than 10 minutes. Here we are doing a simple matchstick test. Just apply 2 matchsticks at the level of penis and just tie with simple thread. If there is erection, this matchstick will break. This matchstick will break. Simple test. Nothing doing. So you can see that there is a nocturnal penile tremulence system. So there is some psychological cause because penis is able to tight at least 50% or 60% during the night. If we are not satisfied with this, we can go for intracavernous injection test. Positive test is rigid erection response that appears within 10 minutes of injection, intracavernous injection, and they last for 30 minutes. Overall, the test is inconclusive as a diagnostic procedure and a duplex Doppler of penis should be requested. So first we have to go for Doppler. If it is not satisfied, then we can go for papaverine test. So duplex ultrasound of penis, we have to see that penile artery peak systolic flow, that is PSV, should be around 30 centimeter per second, 0, 10, 30 centimeter per second, and diastolic value should be at least less than 3. So 3 to 30. And RI should be more than 0.8. So this is normal. If anything devoid of that, we have to see that male is suffering from atherosclerosis or there is a vascular disease. We can go for psychiatric assessment, particularly in younger group of patients more than less than 40 years age with long-term erectile dysfunction. Psychiatric assessment may be useful or helpful for any organic assessment should be carried out. Sometimes we can give sildenafil in the office, give them 100 milligram of sildenafil. 1 hour later we do stimulation of the penis, or we can give them the arousal scenes or videos, and we have to see assess the erection for every 5 minutes for 30 minutes, assess the rigidity and see for bending of the shaft or phimosis. So treatment goals for erectile dysfunction. Many men are not very satisfied with erectile hardness. Erection hardness is an erectile disorder treatment result for desire of the most of the patients. Erection hardness is aimed in improvement to get a good satisfactory sexual relationship. Patient get satisfactory treatment, patient develop confidence, and patient have developed self-esteem that now I am able to do the proper sex with proper erection into the penis to get sexual satisfaction at both level, male and female. Very good things that erection hardness score. There is a very good score given by ILEF, erection hardness score. Severe erectile dysfunction, penis is larger but not hard. Moderate, 11 to 21 is the score. Penis is hard but not hard enough to penetration. It is hard, but when anybody wants to penetrate, it gets looser. Score 3, that is mild erectile dysfunction, 21 to 25 is the score. Penis is hard enough for penetration but not completely hard to do the act, and penis is completely hard, fully rigid, no erectile dysfunction, successful intercourse there, and after this desire of woman or orgasm is there. So 1, 2, 3, 4 are the score. Severe erectile dysfunction has got score of 1 to 2, and no erectile dysfunction has got score of 26 to 30. So successful intercourse is usually done in the score of 3 to 4. Penis is hard enough for penetration, but little loosen can also do the work. But if it is bent, then it is not able to do the proper sexual intercourse. What are the problems? What is the disease management? First and foremost, lifestyle modification. As I already told, erectile dysfunction is barometer of underlying cardiovascular disease, diabetes, hypertension, stroke. So we have to take care of this. If he is smoking, stop smoking. That's why in every movie, before starting of movie, Akshay Kumar is coming and says, you are doing poo-poo. हीरोगिरी दिखा रहा है, 20 रुपए की सिगरेट में तेरी वाइफ के लिए जिंदगी खरीद सकता है. So smoking should be stopped. Smoking hardens the artery, including those supplying to the penis. This can limit the blood flow and causes erectile dysfunction. Increase amount of exercise. In Sanskrit, there is very good norms that ati sarvatra vyarjate. Everything should be there in proper amount. If you are doing enormous exercise, Exercise improved blood circulation, build strength and stamina, mood lift, relieve the stress. But it should not be that much hard because your body muscles get stout. You are not giving exercise to the penis. So everything increase the amount of exercise, not at the extreme level. At the sufficient level, you have to do your exercise. This will benefit your sex life as well as overall self-esteem. Improve your diet. Take very good. Just have a habit of 5 fruits, 5 good vegetables, 5 nuts, less sugar, more water, less salt, less saturated fat and caffeine. Moderate alcohol consumption. In India, in Gujarat, we have got no alcohol, so no need to take any alcohol, but alcohol can cause and worsen erectile dysfunction. Try to stick to the safe limit or no more than 3 units of alcohol per day for men. Always try to manage the stress. Always take stress in your premises, in your working day. Put stress on the table and just leave the stress at your office and go to home. Never take your overload stress at your home. It may hamper your sexual life, and erectile dysfunction or erectile disorder may be one of the cause of that stress you are taking in your treatment. So ED treatment can't do much if you are constantly exhausted, you have got not good sleep, there are so many tensions in your life, and it will cause tension in your relationship also. So good communication with your partner, taking time out, relax, talk with them. For stakers, pick one thing you enjoy and make efforts to do once in a week. Once you are not happy, she wants to do the sex, say sorry, today I am not in a good mood, I have got lots of tension, so we'll do it on next day. Rather than performing on the stress situation, erectile dysfunction will be there and that will increase your problem. Give them the psychotherapeutic interventions. Sex therapy ideally include both patients and the partners. Therapy should be emphasized that blaming one of the partner, it should be avoided. So whenever this patient again coming with the erectile dysfunction, we give them the separate sheet. We give them the sheet that you have to write in this paper, talking individually and talking in person with both, and we are trying to solve the problems. Sometimes behavioral techniques, we use the PSET model, educating the patient, setting the parameters of the therapy, prescribe sex. Sometimes we are saying that you have to do sex weekly, you have to do sex bi-weekly, you have to do daily sex. Particularly in ovulation induction, you have to telling that if you are possible, do for the sex 2 times. As Gandhiji used to say, 2 times are there for good प्रार्थना. उठने के बाद, सोने से पहले. Before you rise, before you go to bed. These are the 2 times very good for sex. If you are giving them ovulation inducing drugs and you are allowing them for the time intercourse. Sunset, focused exercise, systematic sensitization and desensitization of all the problems. There are pharmacotherapy is there, but there are so many different type of first line therapy. For erectile dysfunction, we say that we have to thank all cardiovascular disease person, those who has invented drug for hypertension and used for different drugs, because this all inhibits PDEF inhibitors result in smooth muscle relaxation with increased arterial blood flow, leading to compression of subtunical venous plexus and gauge penile erections. First came in market, that is sildenafil, then comes tadalafil, vardenafil, evenafil, udenafil. These all are filling the penis and giving you very good satisfactory function. That's why they are not low or tall, they are filled. So they are filling the cavernous sinus of the penis. Sildenafil, tadalafil, vardenafil, evenafil and udenafil. Sildenafil we can give dose from 25 up to 100. Recommended starting dose is 50. Always take that you have to take 1 hour before the administration, and efficacy may last for maintain for 12 hours, but it will be around 2 to 3 hours, and sometimes there is a redness in the eye because it is a vasodilator drug. So always tell that there might be little bit palpitation and there might be redness in the eye. Tadalafil administered on daily demand of 10 mg to 20 mg on alternative day base. 2.5 and 5 mg strength is also available. Effective from 30 minutes. So if you have got no 1 hour, you can take tadalafil with efficiency about 2 hours, and efficiency is maintained up to 36 hours and not affected by any food. So tadalafil is also available in market. Vardenafil 5, 10 and 20 milligram doses are there. It is approved on demand by FDA. Starting dose is 10 milligram. Vardenafil is effective again just like Tadalafil, 30 minutes is sufficient, and it is there in blood up to 24 hours. The effect is reduced by heavy and fatty meal. So Vardenafil should be taken empty stomach, or that is 1 or 2 hours after the meal or before the meal. These all are PDE5 inhibitors. Sildenafil, Tadalafil, Vardenafil and Adenafil. Efficacy is very good, 82%. Time tested, old drug, that is sildenafil. Evanafil has also got 81% efficacy. Start time 12 to 37 minutes, 50 to 30 minutes. This is 30 minutes. Efficacy 3 to 5 hours, 24 to 36 hours, and this is 6 hours. Contraindication: if patient is taking nitrite, Tadalafil, the patient is taking sarbitrate, then this drug is not working. So patient is taking any nitrate containing antihypertensive, and this is not working. So what should be the selection for PDF inhibitors? Tadalafil 2.5, 5, 10 and 20, sildenafil 25, 50, 100. For psychological erectile dysfunction, daily dose of tadalafil is working. Mild allergic, arteriogenic, then also give tadalafil. Severe vascular disorder, you can give combination or either of sildenafil or evanafil. Non-consanguineous marriages, you can give sildenafil 50 to 100. There are list of other drugs for erectile dysfunctions. There are lohumbine, delaquimine, trazodone, ginseng is worldwide old tested Chinese therapy. Honey goatweed, ginkgo biloba, mariopuna, conogel, L-arginine. L-arginine has got increased use in gynecology as well as this in male disorders. Second line therapy: if the patient is not satisfied with oral therapy, we can have an intracaverous injection. Intracaverous alpostadil is most efficacious. Monotherapy has dosed from 5 to 40 microgram. The erection appears to be 5 to 15 minutes and lasts according to the dose injected. Complication of intracaverous alpostadil is sometimes penis pain, prolonged erection, primapism, and sometimes fibrosis. We can have a combination therapy of papaverine plus pentolamine, papaverine plus pentolamine plus alprostadil. These all are combined therapy for erectile dysfunction, and this will give a very good result. You can give in combination also, but effect will be last for 30 to 60 minutes or 25 to 30 minutes, depends upon the response of the patients. Sometimes we can use this vacuum erectile device. It is also available on OTC market. This is vacuum erectile device is hollow tube with a hand powered battery or pump, which creates a vacuum that provides progressive engorgement of the corpora cavernosa and pulls blood into the penis together with constriction ring placed at the base of penis to retain blood within the corpora. So this is a just vacuum erection. There is some medical or surgical therapy. We can have a penile revascularization with traumatic blockage of the arteries. We can do vascularization with the epigastric artery to the penile artery. Patient has got, if there is no history of diabetes or hypertension and only this blockage of artery because of the trauma, so we can bypass or we can use this epigastric artery to give supply to the penile artery, that is epigastric artery can be used. We can have a inflatable penile implants or prostheses are there. There are malleable prostheses, there are prostheses with inflatable balloon, and there is a balloon here and we have to inflate that balloon, so there is a penile erection, and with this erection they work very well. This is a penile prosthesis. 3-piece inflatable devices there, and most patients prefer this because of the natural erection is obtained. 3-piece inflatable device includes separate reservoir placed in the abdominal cavity. 3-piece device provides to give very good rigidity, best facility, and it gives a little bit more or natural response to the female partner. Results in firm penis, that is because of the malleable or hard implant can be manually placed in erection and flaccid states. So remember the treatment in erectile dysfunction. First, identify the cause, lifestyle modification, and education and counseling. First line treatment is PDE5 inhibitors. Consider alternative first line options before or second line treatment. Second line, you can use vacuum device, intracavernous injection, intraurethral injections. Third line is penile prosthesis. either inflammable or malleable. Now we can go for ejaculatory dysfunction. Madam, can I continue or should I stop at premature ejaculation? Sima madam?
Hello? Yeah.
I can continue with premature ejaculation?
I think so.
Okay, no problem.
Ah.
Because
This
because
is
we
the
have to
part
stop
of-
at 6 o'clock, na?
Yeah.
So only 15 minutes left. So you have
Yeah.
you have to give the investigation or indications. You have to speak something, na, Sima madam?
Oh, no. We will do it later. We are covering this now. We'll complete it.
Okay.
Hmm.
So again, I will start sharing. No issue.
Oh, no.
So
Just a minute, Manish.
yes, madam.
Isn't is premature ejaculation a separate lecture or part of this one?
This is part of this one only, male erectile dysfunction.
Yeah. So that let's complete one topic. No?
Okay, madam. Okay. So this is the premature ejaculation. What is definition? Male sexual dysfunction, that is premature ejaculation, classified by ejaculation which allows or nearly allows occur prior or within above the 1 minute of vaginal penetration. So many times patient will say that I am not able to penetrate, just I put my penis inside the vagina and there is ejaculation. Or there is inability or delayed ejaculation all or nearly by vaginal penetration. Negative personal consequences such as distress, botheration, frustration, avoidance of sexual intimacy can cause premature ejaculation. New DSM-5 adopted for premature ejaculation definition criteria similar to those accepted by ISSM. Therefore, according to DSM-5, the following criteria are there for diagnosis of premature ejaculation. Criteria A: persistent or recurrent pattern of ejaculation occurring during partnered sexual activity with approximately 1 minute following vaginal penetration and before individual wishes it. B. Symptoms of insertion A. Criteria A: must have been present for at least 6 months and must be experienced by almost all 75 to 100% occasion of sexual activity, significant stressors and not attributed to the effect of substance or medication or other medical condition. What are the different causes of premature ejaculation? Lifelong premature ejaculation. That is islets less than 1 minute. Suppose the hypothesis of genetic determination of lifelong premature ejaculation. This ultimately lead to a discussion about lifelong P as a more neurobiological than the psychological determined condition. Sometimes there is acquired premature ejaculation because of the endocrine factor like hyperthyroidism, the typical hormone risk for premature ejaculation. So always do thyroid function tests in patient with premature ejaculation. Lower prolactin and thyroid stimulating hormone were linked with premature ejaculation, whereas lower testosterone and higher prolactin are linked with delayed ejaculation. So the patient has got no ejaculation or delayed ejaculation was done by Dr. Arsi in first case, but they found retrograde ejaculation. But patient with low testosterone and higher prolactin can have a delayed ejaculation. Likewise, low prolactin and low TSH has got premature ejaculation. So erectile dysfunction, many men who are aware that rigidity starts to weaken during sexual intercourse when try to speed up. Sorry. Ejaculation before rigidity and erection are lost and coitus terminated early. There might be some penile anomalies like short frenulum was found in 43%. After frenectomy and under local anesthesia, they are able to increase from 1.65 minutes and baseline is 4 minutes. Sometimes because of the prostate disease or benign prostatic hyperplasia, chronic prostatitis, chronic pelvic pain can also increase the prevalence of premature ejaculation. There may be cognitive or affective factors. Patients were preoccupied with thoughts after contributing their ejaculation, anticipation of failure. Thoughts may be there that they are able to erect but they are not able to satisfy the partners. Anxiety is most of the most important and common cause and etiology for premature ejaculation. It has been suggested that anxiety is not a criteria for lifelong premature ejaculation. Sometimes because of anxiety they are not able to perform very well and there is a premature ejaculation. Variables like immediate ejaculatory disorder may be lifelong, less than 1 to 1.5 minutes, acquired, very short, nature available premature ejaculation like function. So this very long is constant, acquired is inconstant, natural is inconstant, premature is inconstant. If we look about the etiology, there might be very good etiology found neurological and genetic in lifelong. Some medication that are because of the acquired. There is normal ejaculatory performance in natural premature ejaculation because of the anxiety and that may be related with psychological evaluation, and it is a premature ejaculatory dysfunction that may be a psychological. So for treatment for neurological and genetic cause we have to go for counseling and medication. Treatment if patient is on metoprolol, just atenolol, just stop that atenolol and acquired premature ejaculation will go. For anxiety, give them very good quality of life, education, and it will go. How you evaluate? First step for the treatment of envelope evaluation is comorbid sexual dysfunction like erectile dysfunction or that syndrome, comorbidity of psychological dysfunction, premature ejaculatory diagnostic tool, that is PEDT. Just look for that. Detailed sexual history, again give them years. Key diagnostic means to figure out premature ejaculation in distinguish between lifelong, acquired, situational or generalized. There may be premature ejaculation situation. If situation is not good, he is in anxiety, he is in hurry, there may be premature ejaculation. The initial questions are: do you ejaculate before you want? Do you ejaculate with very little stimulation? How difficult it is for you to delay ejaculation? How you feel frustrated because of ejaculation done before you want? How concerned are you that your time to ejaculate leaves your partner sexually unsatisfied? Thus the erection subsides before ejaculation occurs. What techniques have been used? Most men have used various techniques to delay the ejaculation. They are vary from slowing down, thrusting, thinking distrusting, non-sexual thirst, consuming alcohol, alternative intercourse position. Thanks to Coke Shastra, they had given different 900 position to go for intercourse. See the film Utsav. Mruchakatikam was the original play, and Amjad Khan played the Bhakt Maharishi Vatsayan, and that Maharishi Vatsayan is known as Coke Shastri, and he is defined different position for intercourse. Makes a few thrust, then stop. Sometimes people are going for reverse counting. Sometimes they are seeing here and there to delay the ejaculation. Sometimes they are using different varieties of condoms like dotted condoms or condom with very thin skin. Sexual repeturize. Does the couple engage in sexual activities other than intercourse? Do they continue with their sexual practice or they finish their sexual encounter? C for sexual content. Assess availability of private time and space, especially when couple has got children and they have got single room, two children are there, they are staying with their mother and father, they are staying in a small house. Then also there is a very good sexual content that may cause for erectile or premature ejaculation. Also see for sexual frequency. If your sexual frequency is too prolonged, then there are chances that there will be a premature ejaculation. So that maybe the frequency is also one of the distressing situation. Psychosexual and partner related history. Sometimes lady says that I am ready, you start, and man says I am just finished. That is the cause of premature ejaculation. How partner respond to your problem, because this is not an individual act, it is a combined act, it is a joint venture. So he and she should be there to get the proper excitement, the couple intimacy and general relationship of the quality, communication with the problem. C for concern for fertility. When ejaculation occurs before intercourse, there are chances that there may be no pregnancy or sometimes unwanted pregnancy. So we have to, if they want fertility, then we have to advise them to do intercourse at the time of proper orgasm, so penis can reach up to the posterior fornix and reach up to the desired part, because ovum is resting in the garden of ampulla for waiting for handsome sperm, because life is like a race. So many sperms are there, but only one gets to entry into the ovum. So we have to see for partner satisfaction, orgasm capacity, and sexual practice before penis and vaginal intercourse. So this is PRA, psychological factor, level of sexual experience, condition, and guilt. Relationship factors, emotional, closeness, satisfaction, amount of sexual activity. Attitudes towards sexual activity. That should be personality, sexual performance anxiety, technique and early experience, and sexual performance and anxiety should be there, so patient can have a very good sexual relationship. Physical examination. See that simple complete andrological assessment should be done, as I told, in the front of, suppose woman is stitching in front of men, and always see that rule out the phimosis, hypertensive glands penis, tight underwear, tight jeans, look for the do PR and see for prostate, just palpate epididymis, see for any infection of epididymoorchitis, just see for pampiniform plexus, see for her Valsalva test, and see that he is not suffering from varicose. There are different treatments. Treatments on demand, daily use, patient on demand combination of drugs, and demand combination of anesthetics. First start, see, official, just squeeze, cognizing arousal and continue technique, psychological relaxation technique, sexual awareness training, entrancement arousal, pubococcygeal muscle control technique, and sunset on focus. First behavior, that is start top technique. That is very good technique, that sometimes they are doing reverse counting, some they are stop at the time of ejaculation, so they can have a more time for intercourse and there is no premature ejaculation. So after a short delay in this procedure repeated twice or more, following which woman stimulates and her partners to ejaculate. Later a lotion can be applied on man penis during the procedure, which can increase the arousal and make genital stimulation just like vaginal content. Squeeze technique. When the man indicates he is coming high aroused, his partner should apply a pump squeeze on his penis about for 15 to 20 seconds. This can be done in vagina also. During this application of pressure, forefinger and the middle finger are placed over the base of glans and shaft of the penis, on the upper surface of the penis, with thumb placed at the base of under surface of the glans, so there is no ejaculation. This is a squeeze technique. As the stop start technique is repeated 3 times in a session, and 4th session can go for ejaculation. Cognitive arousal contortium technique. The man systematically observes, considers, and distinguishes those detailed thoughts, actions, feelings, scenarios, and sequence that characterizes individual arousal pattern. Then during the sexual intercourse, the man is able to manage his level of sexual arousal by his sebaceous or judicious concentration. Psychological relaxation technique, 10 to 20 minutes delay of quiet focus on breathing, body awareness, muscle relaxation that is encouraged to concentrate on the physical sensation and to ease body tension. 4th one is sensual awareness technique, that is entrampment arousal. Men focus on visual and tactile exploration of his own body. To achieve ejaculatory control, a man with premature ejaculation needs another arousal style, training the man to become aroused by entrancement rather than partner interaction provides him with the foundation of improved sexual and arousal control. For example, men focus on the pleasurable sensation on his penis rather than on his partner's breast, sexual fantasy or distraction. Last is pubococcygeal muscle control technique. This technique, the conscious capacity to relax the pelvic arousal pubococcygeus muscle. It is a variation of Kegel exercise for women. We know that Kegel has designed very good exercise for female to holding the vaginal cone into the vagina to increase the vaginal capacity. Now we have got very good pelvic floor exercise meters are available to get very good vaginal control. The man is thought to relax and pubococcygeus muscle, that is bulbocavernosus and ischiocavernosus muscle, while expressing the sexual arousal. Couple sonnet focus pleasuring exercise consists of both non-genital and genital phase. When successful alone, The man exercises the same procedure with his partner. After some 4 or 5 successful manual stimulation sensation, couple try to get the stop-start intercourse and then put the penis into the vagina. There are pharmacological drugs available. There are 6 major pharmacological treatment for premature ejaculation. Daily dose of SSRI, that is citalopram, fluoxetine, paroxetine, and sertraline. Non-demand use of doxapatine, on-demand use of clomidopine, on-demand use of local anesthetics, on-demand use of tramadol, and on-demand use of phosphatidyl esterase 5 inhibitor combination with this, or with the exception depoxetine. All these treatments are off-label in erectile dysfunction. Long-acting antidepressants to be given 1 to 2 weeks before to get the very good benefit seen. Prolonged increase in synaptic cleft serotonin, which desensitize the 5-HT receptors. Tricyclic antidepressant like chlorpheniramine 12.5 to 50. SSRI like proxetine 8 to 8-fold delay in ILET compared to sertraline, fluoxetine, and citalopram. Tachyprophylaxis decreases the response to drug following chronic administration. We have to tell them these are the side effects of fatigue, drowsiness, yawning, nausea, vomiting, dry mouth, diarrhea, perspiration, gradually improved after 2 to 3 weeks. This may sometimes decrease the libido, anorgasmia, anejaculation, and erectile dysfunction, so should not be stopped abruptly. Avoid in men with depressive disorders. If she is suffering from suicidal tendency, don't give any of this medicine, just give them the psychological support. Desensitizing agents like local anesthetic agents. Local anesthetic agents reduce sensitivity of glans penis through the delayed ejection response. This you can use lidocaine gel 20 to 30 minutes before intercourse. Prolonged application 30 to 40 minutes, loss of erection due to numbness of the penis. Condom will also prevent diffusion of the topical anesthetics. Alternative condom may be removed prior to sexual intercourse and penis washed clean for the residual active compound. It is contraindicated in patient with allergy to latex, and this is a level 1B suggestion. We can use tramadols. There is a atypical opioids. Activates opioids receptor centrally and inhibits serotonin and non-adrenaline uptake. Readily absorbed after oral administration and has got effect of 5 to 7 hours. We can use on-demand dopaxetine, 60 to 89 milligram increase in ILTS by 2.4 and 2.5 times. 15% discontinue because of the nausea, vomiting, dizziness, and it is not recommended for premature ejaculation. Doxapatine hydrochloride, it is a short-acting SSRI, rapid Tmax of 1.3 hours and short half-life of 95% clearance in 24 hours. We can give on demand. Dose is 30 to 60 milligram. Effect starts from first dose, but there are lots of side effects like nausea, diarrhea, headache, dizziness. Discontinuous effect because of discontinued is there for the 4%, and no withdrawal symptoms, no drug interaction, so it is a level 1 good drug. Phosphatidylsterase 5 inhibitor, sildenafil versus placebo does not improve ILTS, improves satisfaction, confidence, reduces the refractory time, achieves second erection after ejaculation. So sildenafil plus physical therapy, SSRI plus sildenafil is better monotherapy with SSRI of proxetine and sertraline. Sildenafil with chronic SSRI provides good symptoms of vasovagal reaction. Sildenafil, doxapatine are well tolerated. Limited data available. This is all non-off-label use and should not be used in patient with evidence of erectile dysfunction. Thank you very much, madam. Thank you for patient listening. And at the end, everybody should be happy because our patient should not suffer from any erectile dysfunction, neither male or female. So Babaji says is very right. Just listen this.
The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here.
Everybody can sing.
The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right
Here. Thank you very much. Thank you on behalf of my all residents, those who have prepared my presentation. Thank you, Kishan. Thank you, Vaishvi. And again, good evening, all.
What a beautiful presentation, Manish.
Thank you, madam. Thank you.
And I don't think after this any doubt is left in anyone's mind. However, we are exceeding time, but if anyone has any question, guys, please ask. Feel free to ask.
Because this topic is very less encountered, but it is present in the life. So discuss with them, and so many times after just discussion, so many infertility patients are conceived just after counseling. But there is no any other problem. There may be erectile dysfunction, there may be arousal difficulty, and they are coming to you for infertility treatment. So give the yes, listen them carefully, and you can diagnose so many things in your life.
Unknown caller.
Okay.
Thank you so much.
Thank you, thank you,
Thank
thank
you,
you.
ma'am.
Thank you.
So, Poonam, I don't think anything is left here. And there's no question. So, can you wind up the session now? And the remaining lecture, whenever there is some slot left, I'll take it. Fine. Poonam,
Yes, ma'am.
I'm saying the other lecture which is left now. Whenever there is some slot vacant, I can take Dr. Shilpi if she is available. She will take it, है ना?
Yes, ma'am. Yes, noted, ma'am.
ठीक है? Okay, Manish.
Thank you, madam. Thank you, Poonam ji. Thank you, ICO ji. And all the best, all the students. Do very take care of your patient. Give the ears and do the things very carefully. Thank you, Sima madam, and thank you, Poonam. Thank you, SOG, and all the best, Dr. Arshi. I listened your case very carefully. So during my presentation, I talked 2-3 times your name, madam, because you had taken very good history. And by definition, history is study of past in light of presence to have good future. Okay? So retrograde ejaculation is not a disease. Okay? Thank you. Thank you, madam. Now I am leaving the meeting. Thank you. Bye.